Hello and welcome to another podcast. Today we're going to continue with medications and we're going to look at adrenaline. So it is still used in cardiac arrest for shockable and non-shockable. Okay, there's done a lot of trials in that space that I won't talk too much about, but current recommendations is still to use in both shockable and non-shockable. Its primary use outside of that is in anaphylaxis. There is a strong link associated with using adrenaline first if you believe it's anaphylaxis before moving to salbutamol for any respiratory concerns. Another option that is available is using it as an infusion. So setting up a adrenaline infusion can be done in order to help maintain someone's blood pressure or to control some very unstable anaphylaxis. Now, that's obviously on medical officer's advice, but if you want to know not a good way, but a way in which we can do it in the absence of syringe drivers, then check the link above and it's a bit of more explanation on what a vasopressor or adrenaline is and a nice easy equation for how to do it in a field environment. Okay, let's talk a little bit about anaphylaxis. For many years we've been teaching anaphylaxis to CFAs. We mentioned it to first aiders. Ourselves have been taught what anaphylaxis is, and with all this knowledge and education that's going around, there's still a lot of confusion associated with what constitutes an allergic reaction versus anaphylaxis, to the extent that the main reason people die from anaphylaxis in hospitals is actually a failure to recognize that it is in fact anaphylaxis and they should get adrenaline. Okay, to the extent that a lot of organizations are now recommending that the administration of adrenaline should be done even if you're in doubt. So we'll have a look at some of the signs and symptoms and things that we've been told in the past that just may not be that much of a cardinal sign. Okay, so we'll start with the classic, which is the skin conditions. So generally mixed up with skin and mucosal tissue conditions where we have generalized highs, pruritus, flushing, swelling of the lips and tongues. Now these are classic signs of anaphylaxis. Quite often they are far more subtle than people give them credit for. Okay, so we're talking about a very fine generalized hives. The swelling isn't comical, okay, it's actually just quite subtle, that a lot of people don't pick up on that. So when you see that and you have respiratory compromise, so we're talking dyspnea, wheezing, bronchospasms, things like that, and or a reduced BP, then that's anaphylaxis. Another way to look at anaphylaxis is you can not have the skin condition at all, and you can have respiratory and the blood pressure, or you can even have respiratory and gastrointestinal problems where you get the really strong abdominal cramps and uncontrolled vomiting as well. Okay, so the bottom line is skin is common, but not always. You need skin and one other respiratory or blood pressure, or you can have respiratory and blood pressure or respiratory and gastrointestinal in the absence of skin in order to denote it as anaphylaxis. And you can also just have a patient that's been exposed to a known allergen that has nothing else but a reduced BP. So if the patient's been exposed to a known or a potential allergen, has respiratory distress, a lowered BP or strong gastrointestinal problems, the presence or absence of hives and swelling in the skin is irrelevant and adrenaline should be given. Okay, so let's have a closer look at our adrenaline. It's what's known as a sympathomimetic agent, and it obviously works on your sympathetic nervous system, hence where it gets the name from. So its absorption, as you would imagine, is absolutely rapid. So its common ways of administration is IM, subcut, and IV. So when administered IM, it takes about 3 to 5 minutes to be absorbed. Okay, now there's a few studies out there that sees that subcut has the same rate of absorption as IMI. There's even a couple that say that it actually has a better rate of absorption because of its reduced alpha effects. The IV is pretty much instant. Okay, if it's taking longer than 30 seconds, then you're not really going to get a reaction from the adrenaline. Now, whilst it peaks pretty early, it can actually last for up to 4 hours. So people can have the effects for around 4 hours after an IMI injection. Okay, it's metabolized in the body by the MAOI in the adrenal neuron, and it's eliminated by urine. Okay, now its distribution is everywhere. Everywhere that there's adrenal neurons associated with the sympathetic nervous system, you're going to get effects on those receptors. Now, speaking of receptors, we'll move on from pharmacokinetics and we'll look at the pharmacodynamics. Now, adrenaline, most people have a fairly good understanding on what effects adrenaline has. So we're going to spend more time talking about whether it's a strong effect or more of a relaxed effect on those ones. So it's no secret that it affects your alpha and your beta receptors. Now, we have a tendency of breaking up alphas and betas, alpha 1, alpha 2, beta 1, beta 2, but anything that can stimulate alpha 1 can stimulate alpha 2. So if it's a beta 2, then it's definitely going to have effects on beta 1. What it comes down to is how selective and whether or not the drug is designed to get to those receptors, which will determine how great the effects are. So adrenaline itself has a very strong alpha effect. Okay, so the alpha effect, it causes an increase in cardiac output, okay, and an increase in the heart rate because of that increase in your preloading. Okay, but then it also has a decrease in your renal perfusion. Okay, and it does this by causing systemic vasoconstriction. Okay, and also increasing vascular permeability. Okay, a few other things that the alpha receptor, alpha 1 receptor does is it's associated with secretions in the salivary glands and your sweat glands. Okay, it also causes contraction in your stomach and intestinal sphincters. When you're looking at alpha 2, it's a little bit more simple. They're just associated with your intestinal secretions, and they also decrease your insulin secretions. Okay, so your alpha 2 is mostly associated with intestinal secretions and slight smooth muscle contractions. Alpha 1 is where you get your main smooth muscle contractions, which causes your vasoconstriction. Okay, now that's the primary reason that it is still given in cardiac arrest, is to increase that preload into the heart in order to hopefully get a greater output. It affects on the beta side of the house. You have beta 1 effects. Now that is a strong increase in heart rate, okay, so what's known as a positive chronotropic effect, and it also has a greater myocardial contractility. It increases atrioventricular conduction as well, and it's associated with lipolysis, so it actually breaks down fat tissue. It helps regulate blood pressure as well, beta 1 does, by increasing the release of renin and the antidiuretic secretions as well. Its beta 2 effects are quite moderate, okay, so they're nowhere near as strong as the alpha or the beta 1, okay, but it does have a beta 2 response, but mostly associated with bronchial smooth muscle relaxation. Now, the reason that's beneficial, that doesn't have all your beta 2 responses, is because beta 2 is associated with vasodilation instead of vasoconstriction. So, mild beta 2, often associated with the bronchioles, and we also have a little bit of effects on glycogeolysis and glycoeogenesis as well. So it increases the use of sugars to be used for energy. Okay, on top of that, it has a secondary effect, if you will, by modifying your IgE-mediated allergic reaction responses. Okay, so it actually stabilizes your IgE so they don't stimulate the mast cells, they don't work with the mast cells and the basophils in order to release the histamine. Okay, so they calm down that activity as well, which are, as we know, they're massive internal vasodilators, and is actually what causes the swelling during anaphylaxis. Bottom line is, it is a great drug to use for anaphylaxis. It is a great drug to cause vasopressin, but it is a catecholamine, so too much of it or prolonged use of it is obviously going to have some nasty side effects. And because it is catecholamine that you are introducing artificially without the rest of the body getting ready for it, you can also have some undesired side effects. So let's have a look at some warnings and some adverse effects. So the good news is because adrenaline is used when it's used, which is a life-threatening situation, there is no contraindication when it is being used in a life-threatening situation. Okay, if you're using it outside of that, then there's a lot of cautions, a hell of a lot of cautions that we'll go through. But the big contraindications are you don't use it in labour, and it has a horrible effect on patients suffering from narrow angle glaucoma. So in the absence of a life-threatening situation in those two, it is contraindicated to use. As far as the cautions go, there's cautions associated with cardiac disease, angina, anyone that's had CAD surgeries, anyone with pulmonary edema, because it may worsen the effects. If anyone has cerebral vascular insufficiencies, a risk of a stroke or cerebral hemorrhaging. Okay, its use IV is very restricted and can result in a pulseless arrest as well. So not a surprise, but can be quite a dangerous drug, which is why people are a little bit hesitant to use it, despite the strong recommendations in using adrenaline if there's any doubt whether or not it's anaphylaxis. Some of the strong and well-known side effects is your arrhythmias because of its effects on the receptors. You can also get hypertension, which is sort of one of the effects that you want. Strong link to apprehension, anxiety, nervousness, restlessness. You can also get associated tachycardia. So patients who have been given adrenaline as a result of an emergency will often complain that they feel like they've been hit by a truck. They feel very exhausted after the main effects have worn off. As far as interactions go, there are a lot. Okay, there are a lot of drugs that have strong and moderate interactions with them, but in the situations in which we are giving it, it doesn't matter. Okay, life-threatening situations, you give adrenaline. Now, point to note is if people are taking antagonizing beta-andrenic blockers or alpha-andrenic blockers, you are going to have a lesser effect associated with the use of adrenaline. Okay, in some cases, the use of things like glucagon is recommended first in order to release the catecholamines to increase someone's blood pressure, as opposed to adrenaline for people that are on these andrenic blockers. Associated with anaphylaxis, so it's given IMI. Now, its recommended administration is deep lateral thigh. Okay, so lateral to mid thigh is where you give it. You don't give it in the arm, and you certainly never give it into the gluteus maximus. It is deep thigh, and that's it basically. Okay, now if you are giving more than 2 doses, it means someone has quite unstable anaphylaxis and needs a lot of management. Okay, so you really should be calling the MO for advice and working on evacuation for anyone who's been given adrenaline. But if you need more than 2 doses, okay, that is a good sign that their anaphylaxis is quite severe and very unstable. Okay, so ups the ante in how much. Now, I don't know many doctors out there that would not let you give another one if it is needed, but it's just an indication of the overall care that the patient needs after 2. Okay, finish up with some clinical take-homes. When you're dealing with anaphylaxis, the important thing is you need to prevent further exposure. So if someone's getting an IV infusion, you need to stop. If someone's eaten something, okay, you need to try to remove it from their mouth. However, do not delay the administration of adrenaline to remove the sting, to remove the food from the mouth. I don't know how many scenarios I've seen where medics are doing it with CFAs and they make them clean the patient's mouth out before they administer adrenaline. Okay, this is incorrect. Administer the drug, then remove the sting or the food afterwards. Okay, be aware that when you are working with the 2 different types of drugs, okay, the 1 in 1,000 and 1 in 10,000, is associated with a lot of drug errors in ED, to the extent that the US and the UK are looking at getting rid of the 1 in 1,000 and only carrying the 1 in 10,000 drug in hospitals. Okay, so if they can make mistakes and they use it every day, and you're in a situation where you're using both, just be careful. Take your time, make sure, look at what concentration you are using, and then give the appropriate dose. When you're drawing it up for anaphylaxis, use a 1 ml syringe, okay, not an insulin syringe that's written in units. So use a 1 ml syringe and only draw up what's required. Okay, a lot of people get into the habit of drawing up the whole ml and then injecting half a ml into the patient. Now, whilst you practiced, you're concentrating, it's easy to do in a controlled environment. Sometimes, and quite regularly, it is very easy to push in an extra amount of dose into the patient and therefore increase the probability of adverse effects. So, because we don't do it every day, it is recommended draw up just half the ml, inject the half a ml, swap the needles, then draw up the second half. If you are giving more than one dose, rotate the sites. Okay, so use the left thigh, second dose use the right thigh. Okay, remember the alpha effects can last up to 4 hours. Okay, adrenaline can stay in the body up to 4 hours. Means you're going to have associated vasoconstriction in the site, and if you inject something over the top, then you're going to reduce the absorption and distribution rate. If you are giving the patient adrenaline, lay them down flat if they're conscious, and if they're unconscious, protect their airway. Okay, either with an adjunct or rolling them onto their side. If they're suffering from anaphylaxis, they are going to need supplementary oxygen, so don't forget your complementary treatments of O2 and also the need for IV fluids as well when treating for anaphylaxis. Okay, that finishes the lesson on adrenaline. I hope you got something out of it. I hope you had you think a little bit more about anaphylaxis and when to use adrenaline. Remember, the bottom line is it's not always the telltale signs that you may have heard about, and recommendations is if you believe it could be anaphylaxis, give adrenaline. Until next time, take care.